Hello, everyone.
Hello, Wissam.
And I think Dr. Bungar is here.
I have the same problem. I cannot start the video.
What does it say?
It say host.
By the host?
Not, yeah, it's not
Okay.
supported by that.
Okay, the host is going to do that now. Yeah. Thank you. You can see.
Okay, Doctor.
Howard? Yeah, it's working now. Thank you.
We'll start at 7. We have about 5 more minutes. Can you check Dr. Bulgar's video, please? Perfect. We're here. Great. How many are in the waiting room right now, team?
Wissam, I can see 5 questions so far.
Yes, get them already. They'll take care of it. Don't worry.
All right, 26.
Right now we have about 800 and 900 in the waiting room, going up to 900 in the waiting room.
All right.
We'll give them 4 more minutes. It's 6:56 right now. How is the weather there, Arlene?
It's actually very nice today.
Oh, great.
Sunny. Yeah.
You know, Eileen, we are the only country which guarantees sun.
Well, we don't guarantee sun, that's for sure.
I know. We guarantee it for 10 days.
We got to 1,000 right now, 1,200 nearly, going up. Eileen, the audience is going to be mixed between physicians, surgeons. We may have nursing. We may have OR techs, allied health, respiratory techs. So you'll get a wide variety of maybe questions that are maybe related to other disciplines apart from medicine, or sorry, apart from surgery.
Okay.
But that's our end.
وسام في يوم أنا بحاول أدخل على الواتساب وأطلع أشوف if it work, okay?
Sure.
عشان لو يسوي لي summary للquestions من طرفك مثلا, it would be nice. Okay, now let me just go back. Yeah, I can come back. Very good. So maybe after half an hour, if you choose the important questions, because looking now, it's 83 questions. It will be difficult to go through them. So if somebody choose and send by WhatsApp, for example,
I guess we can.
What do you think? I know most of it related. There's no voice or something like that. So
yes, can we just, I think, start now? Everyone is coming in from the virtual waiting room. So can we start now? Ala barakatillah. Let's go.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good evening, everybody. Thank you very much for joining us on this webinar, which is part of the hashtag Imtinan, which is translated Gratitude Initiative. This initiative was introduced by the Saudi Commission for Health Specialty to support everybody, particularly professionals, in this difficult time. you know, it has three parts: the psychological, the operational, the scientific support, and this is the third webinar series in the scientific support, and it's actually the first international. We are very lucky to have Dr. Eileen Berger to join us in this scientific webinar, and we'll give some information about her. As you know, coronavirus, the COVID-19, is affecting the whole world in this outbreak. Unfortunately, the toll is keeping going up. We have reached now over 1 million people infected. The last numbers on mortality is over 54,000. Unfortunately, yesterday in the United States, it recorded highest record in the world in mortality, which is 1,200 people died yesterday. We are very lucky in Saudi Arabia so far. We have 2,039 cases and only 25 mortality, and our curve has been steady for the past 5 days to 7 days, thanks to the efforts run by different sectors, Ministry of Health and others. So our government is taking it serious. However, you know, nobody is immune, and we have to be ready for crisis. And also, being part of this world, we need to know what's going on and be ready for if things goes wrong. Today, we having a leader from the American College of Surgeons. Let me just give you a brief information about the American College of Surgeons. It is a scientific and educational organization of surgeons that was founded in 1913 to raise the standard of surgical practice and improve quality of care for surgical patients. The college has more than 82,000 members, which is make it the largest surgical organization in the world. Today, we are very lucky, as well as we are grateful to Dr. Eileen Berger to join us in this webinar, giving us some of her precious time to share with us her experience and the college experience in handling this crisis, where the American people has been hit strong. As you know, almost 1/4 of the cases almost now in the States. Dr. Berger has received her undergraduate degree from Johns Hopkins University and had her medical degree from Cornell University. She then completed her surgical residency and fellowship in trauma and critical care at the University of Washington. She joined the faculty at the University of Washington in 2000, where she is now a professor of surgery and the chief of the trauma at Harborview Medical Center, which is the only trauma level 1 trauma center for adults and pediatric in Washington States. Her current research interests include resuscitation strategy for hemorrhagic shock, trauma system development, and the pre-hospital triage of injured patients, the biomechanics of injury after motor vehicle crash, modulation of the inflammatory response after injury, and necrotizing soft tissue infection. Her research has generated over 250 peer-reviewed publications. She has served in several leadership roles in Washington State's trauma system, including chair of the State Emergency Medical System and Trauma Steering Committee, and president of the Washington chapter of the American College of Surgeons. She is currently served as the chair of the American College of Surgeons Committee on Trauma. She has been a member of the United States National Disaster Medical System Trauma and Critical Care Response Team in 2003. So we are very lucky to have Dr. Eileen joining us, and we are very grateful for her. Please put your questions. I know we have so many questions. So far, we have about 284, and the number just keep going up, and we will address as much as we can, especially the relevant questions. some of the questions about the voice, the sound, etc. But I think those technical questions will be dealt by the technical team. She will have a 10-minute presentation followed by open discussion, and we hope we can address some of your questions during this webinar. Thank you very much, Dr. Berger, and thank you for sharing with us your experience and giving us some of your precious time. Please go ahead.
Thank you, Dr. Al-Turki. I'm going to put my slides up here. Make sure that that works okay. It looks like everybody can see my slides, hopefully. So again, thank you so much for the invitation to spend some time with you this evening. And I do think that these are really, truly unprecedented times for the world. And I've been encouraged by the fact that people have come together. And I've seen the work of scientists and the medical community all over the world coming together to tackle this epidemic. And that, to me, brings me hope. I'm going to talk a little bit about the healthcare response and some of the work that we have published through the American College of Surgeons that is available to you on the website, but I'm going to spend a little time in detail on that. So just as background, as Dr. Al-Turki said, the American College of Surgeons is a professional organization, and we represent surgeons of all specialties from all around the world. As he said, we have 82,000 members worldwide. We have chapters in many countries, and because of the work of the Committee on Trauma, which began in 1922, we really have a worldwide presence through the Advanced Trauma Life Support course. And Dr. Al-Turki is a member of our executive committee and is the chair of our International Injury Care Committee. And we're very grateful to him for all the tremendous work he's doing to advance trauma care around the world. This is the reach of the Advanced Trauma Life Support course, and I put this up here again to show how connected the world is. And I think as we have built a community around the care and the support of trauma patients and the education through ATLS, that community is now coming together to tackle this epidemic as well. And so, again, we're a very connected world, and we're all in this together. The American College of Surgeons has a website, and most of what I'm going to talk about is available on that website for free, so please access it. There's a special section on the COVID-19 epidemic and resources for the surgical community, and this is the link to the website. I'm going to start, though, with our own story. So as was mentioned, I'm from Washington State, which is in the northwest corner of the United States. You can see there a population density map of the state. We have most of the population around Seattle, which is in the Puget Sound Basin here, between two mountain ranges. And then we have some population areas out in the eastern part of the state, but the most of the eastern part of the state is quite rural. We were the first case of COVID-19 that was identified in the United States, and that was on January 21st. Was a traveler who had returned from Wuhan, China, who became ill and was hospitalized, fortunately recovered. But that was the first case in the United States. And just about a month later, we identified the first death in the United States associated with COVID-19. And through the tremendous work of the epidemiologists, they traced that death to a long-term care facility, which is a facility that cares for elderly patients who can't be cared for at home, often due to medical comorbidities. In that single facility, we identified 129 cases, 81 of whom were residents of the facility or patients, 34 were staff of the facility, and then there were 14 visitors. And of that population, 23 patients died. So we had a very large outbreak in this single facility that was identified very early on, and the first deaths reported in the United States. This becomes really important when you're tracking this disease because it does impact vulnerable populations such as this. And in this case, because of the staff that were also infected, many of whom did not show symptoms, and worked at multiple facilities, this spread to other long-term care facilities in our region, and we're currently tracking cases in over 60 of these long-term care facilities in Washington state. So this is where it first popped up for us, but it's certainly a group that's at very high risk. This is what the data looks like in Washington state now. So I mentioned that first death was identified at the end of February. You can see we've had a steady increase in the number of cases. Fortunately, the number of deaths has been much less than that. Part of the challenge here, of course, is the availability of testing, and how much you can test helps you identify both where the hotspots are and what the prevalence of the disease is in society. One of the advantages, I think, of having one of the first cases in the United States is that we worked with our virology lab to stand up our own testing very quickly, and we're able to ramp that testing up really ahead of much of the rest of the United States. You can see now that we have cases spread all across the state. Every county now has essentially seen at least one case, but the vast majority of the cases remain in that part of the state where most of the population lives. This is where I live here in King County, where the majority of cases are and the majority of deaths as a result. But we are starting to see hotspots in areas where there are other significant amounts of population as well. If you look at the breakdown of deaths, what we've seen so far is that the vast majority of the deaths are in older patients, particularly older patients that are over the age of 60, that have significant medical comorbidities. That we have seen critical illness in young people, particularly in some healthcare workers, but they, fortunately, the vast majority of them recover. But they can be critically ill, and they can require a mechanical ventilation. I would be remiss as the chair of the Committee on Trauma not to remind us, though, that there are lots of other things that we deal with in our healthcare system that can be impacted by this epidemic. And as you know, injury is a major public health problem in the world. This is data from the World Health Organization in deaths per year in millions for injury. And so as we are working very closely through our healthcare system to address this epidemic, it's critically important that we not forget the other time-sensitive emergencies, such as injury, stroke, heart attacks, all of those things that we take care of on a daily basis. And if we can't accommodate them in the healthcare system, then they will be casualties of this, even if they don't contract COVID. And so we have to keep that in mind. With that in mind, one of the first guidance documents we put out through the college, through the work of the Committee on Trauma, was this document called Maintaining Trauma Center Access and Care During the COVID-19 Pandemic. And this is a guidance document that was written for trauma medical directors, trauma program managers. Those are physicians and nurses that run our trauma hospitals in the United States, but really around the world. I think this is applicable. And I'm going to share with you some of the highlights from that document. In that document, we talk about two real key components here, both regional planning and hospital planning. And I think especially now, if you're in the early phases of this epidemic, these are the things you should be thinking about doing. So from a regional planning perspective, it's really about what is the communication strategy and the coordination among hospitals. Because what happened in our long-term care facility outbreak is the hospital that was very close to that, which is a relatively small community hospital, received all of those patients and was quickly overwhelmed. And so there needs to be a mechanism to be able to distribute, especially the critically ill patients, among multiple hospitals so that you can have the appropriate resources to care for them. So what does that coordination plan look like? The other big topic that's very active right now in the media in the United States, but is actually something that we've been working on for many years, is the concept of crisis standards of care. And I'll talk a little bit more about that, but that is how you make decisions about care for patients when you don't have enough resources to care for them. For example, you don't have enough ventilators for the number of people that need them. We hope to never get to crisis standards of care, but I think it's very important as a medical community that we have those discussions now, so that if we get to a situation like that with this type of pandemic, that we know what we're going to do. The other big area is obviously hospital planning, and there are several factors here that are really important. How we protect healthcare workers, and I'll talk more about that because healthcare workers are at risk if they're not adequately protected. I'll talk from a surgery perspective about how this impacts our trauma response in the emergency department and operative issues, and then I'll talk about the impact and some planning for intensive care. So from a regional planning perspective, this is a map of our trauma system, all the hospitals in our state that are part of the trauma system at different levels. We have some basic infrastructure for communication that we do on a regular basis and that we use when there's a mass casualty event. So if there's a bus crash or a large number of people that are shot or injured, we have a really good mechanism to quickly stand up a communication platform that allows us to distribute patients. However, that's not sufficient for this event. We have recognized pretty quickly that this is a much longer standing event. It involves every part of the healthcare system. It requires that we monitor and track those long-term care facilities, and that we really have what we call situational awareness, or the ability to know what is happening in every hospital in the state, what their bed capacity is, what their supplies are, how many ventilators they have, what resources they have for protective equipment for their providers. And so we've had to quickly, working with Microsoft, establish a platform to be able to collect that data from every hospital, from every EMS agency, and then have a dashboard that allows us to track it. This way we can identify if there's a healthcare facility that's in trouble and hopefully offload them and distribute patients more effectively. So this sort of regional coordination and planning, I think, is critically important. We have put together another guidance document from the American College of Surgeons about this that should come out in the next couple of days. It's not on the website yet, but it is critically important as we gear up for what is likely to be a very long response. These are some documents on crisis standards of care that we have worked on for many years, and the concept really is that in normal times we're in sort of conventional capacity where we have more than enough supplies to take care of every patient the way we would like. As things get stressed, we move into what we call contingency phase, where we have to change the way we practice some, but we can still deliver an adequate standard of care to every patient. And crisis is where you get to the point where the number of patients really outstrip your resources, and you're really in a situation where you can't provide the standard of care to everyone that you would like. So the goal always is not to get into crisis, it's to manage the system in contingency, and we are certainly in that phase right now in the United States. But this is just an example of things that you can do if you're worried about ventilators as a critical resource. These are created through our regional planning process. They're available on the website of the Northwest Healthcare Response Network, which is our disaster response network that represents all of the healthcare systems in western part of Washington state. When it comes to hospital planning, the first thing we did very quickly was stand up our incident command structure, which we put together usually for discrete events. It's been running ever since that first death in the end of February now. But that's daily briefings of all the leadership of the hospital, looking at all of the different things that we need to do to prepare for the surge of patients. We established discrete places in the hospital where we could create negative airflow in large units to cohort the COVID patients. So we have a dedicated COVID ICU space and dedicated non-ICU space for those patients. We have worked with our engineers to expand that into several other ICUs and have essentially doubled our ICU capacity as a result of this event. So it's not too soon to start to think about what spaces in your hospital can be turned into negative pressure space for an ICU. We've also worked to expand our personal protective equipment, ventilator resources, and worked out a staffing model so that we can expand the staffing for this ICU surge. Importantly, early on, we stopped all elective surgery procedures. This was a guidance that came out from the American College of Surgeons for the hospitals in the United States, anticipating how significant this epidemic was going to be. This is not an easy decision. Many patients have waited a long time for their elective surgery. It's important to them. It's a source of income for hospitals, but by stopping elective surgical procedures early, we were able to preserve the PPE, or the personal protective equipment. We were able to redirect resources to planning and preserve our blood supply, which also has become short because of blood donors not coming out and staying home. So it turned out that this was a very important thing to do, but it was a very painful decision for most hospitals to make. We also stopped all non-essential clinic visits, again, to redirect our resources. We have stood up telemedicine options for patients so that patients who need to be seen by a physician but don't have to come in, we can work with them electronically. And we have also limited hospital visitation, which was also very challenging because obviously families want to visit their loved ones, especially if they're critically ill. But because of the risk of disease transmission and for managing healthcare providers, we have severely limited hospital visitation policies. The other big debate that we've had is around who should be tested. And so this is currently what we're doing. Again, I think testing for COVID depends a lot on your resources. If you have the resources to test more people, you're better off because then you can identify where problems are in the community and hopefully head them off before they become large outbreaks. But at this stage, we are testing only symptomatic patients. So if you're not symptomatic, we're not routinely testing you. If you are not symptomatic, the only time you might get tested is if we're going to do what we call an aerosol generating procedure, which includes intubation within the next 72 hours. So if there's some reason that we need to operate on you, we will test you to know your status before that procedure is done. If you have symptoms and you don't require hospitalization, we often also don't test those patients but send them home on quarantine, assuming that they're positive but preserving the testing materials for patients that need to be hospitalized. The other group that we routinely test that's symptomatic would be healthcare workers and first responders because we need to know when they can, whether they are positive or negative and when they can go back to work. We also are testing patients who are at high risk, like immunocompromised patients and pregnant patients who have symptoms. This is another nice paper that I would refer you to that's published just this month in the Journal of the American College of Surgeons that talks about the surgical response to COVID-19, and you can see it's laid out very nicely in sort of different levels that you would go through as you started to encounter this disease. So in the first phase, you really haven't had any patients yet, but you're aware of the problem, you're starting to plan. It gives you advice as to what to do. And even at that phase, they start to talk about canceling elective surgery for high-risk patients so as to not bring patients into the hospital that might be at high risk of getting ill from COVID. In the second phase, when you start to have patients with COVID-19, it's a time to really be very cautious about your resources and dropping elective operations, creating a pool for staffing and starting to expand your ICU space. And then you can see as it gets worse, then all attention turns to COVID. I would say that the challenge, though, of all attention turning to COVID, which is what it frequently does, is not to lose sight of those other emergencies that we talked about, like trauma, cardiac, and stroke. I can't say enough about the importance of supporting your healthcare staff through this process. This is stressful for everyone, and particularly for the frontline staff and the nurses. You have to manage your personal protective equipment tightly so that they have access to that. We actually had to put it under lock and key so it didn't walk out of the hospital with somebody. We had to establish protocols for the appropriate use of PPE in different settings and for reuse of PPE. So many of the devices, even though they weren't designed for reuse, can be reused and after they're cleaned, and so we have been doing that. We had to train staff in how to appropriately use this equipment, and I'll show you some simulation photos of that, but it's critically important that they learn how to take it on and off without contaminating themselves. We had to convince staff who had any symptoms, any respiratory symptoms at all, not to come to work, and that's not the culture of healthcare workers. They're used to working even when they don't feel well, and we had to convince them to stay home, and we had to provide them access to testing. Regular communication with staff was critically important, and you can't over-communicate in this situation from my perspective. We tried to adjust staffing schedules so that they were not overrun, and especially early on, since we expect this to be a very long course. Most ICU patients need at least 2 weeks in the hospital on a ventilator. If they're on a ventilator, at least 2 weeks, and so these are long ICU stays. We worked on backup schedules and for healthcare workers that are out with illness, and all the schools closed down, so we had to work on childcare planning. Many of our nurses, have childcare issues, and that becomes a real challenge. And then we've done a lot of work around staff recognition and trying to support them during their jobs. This is the other resource on the American College of Surgeons website that talks specifically about elective cases. Each one of these categories has a guidance document that sort of defines what's emergent and what's not emergent for each specialty, and that gives you an idea of how you should prioritize what cases you're going to do or not do. And I think that's a very useful resource, and it was written really by the leaders of all of those different subspecialty groups. When it comes to procedures, there are specific issues to think about. Any aerosol generating procedure, the most common ones being intubation and endoscopy, are at increased risk for healthcare provider exposure. And so we have worked on specific protocols around those. We have a dedicated team. They're in special airborne precautions to protect the healthcare team. There's been a lot of debate about laparoscopy versus open surgery and whether there's risk of viral exposure during those procedures. There's very limited data. Some viruses are aerosolized through laparoscopy or surgical smoke, but really we don't have any data with this virus. We are not recommending that you don't do the surgery if it's needed, but there is recommendation about using a special viral filter when you evacuate the CO2 from laparoscopic surgery, and smoke evacuators for open surgery. And again, all that information is on the website, but these are things that I never thought about before and had to think about in the last 2 weeks. We've also struggled with preoperative testing because you have to balance the logistics of getting the test done in a timely fashion against the timely need for surgery. But we are testing whenever it's feasible. And if we can't test, then we're treating them as if they're COVID positive. We're doing a lot of training with the staff. As I said, everybody has to be fit tested who's going to wear an N95 to make sure it doesn't leak. And if they can't wear that, then they get PAPR training. You can see here that these providers are in what we call PAPRs or positive airflow devices. And we just have to train how to work in these devices. It's not the way we're used to working, and it's stressful, it's hot, and it requires a good teamwork and communication. When it comes to the ICU, there's terrific resources at the Society of Critical Care Medicine website. I've used those they have an ICU preparation checklist. They have surge planning documents. They have just-in-time education. So if you have providers that are going to have to work in the ICU that don't usually work in the ICU, there's education here that's free on the basics of critical care and caring for patients with acute respiratory distress syndrome. And they've also posted lessons learned already in caring for COVID-19 patients. So I think this is a terrific resource for those that are getting ready to surge in their ICUs. The epidemiologists in this event have been extremely helpful to us, and we have an Institute for Health Metrics and Evaluation at the University of Washington that has a website that has been modeling the disease over time, and it's been very helpful for us in our planning. I would hope that you have epidemiologists doing the same thing for your country. This is just a screenshot from their website, which you can access. You can actually, this is for the whole United States, but you can look at it by state. But they have modeled based on the amount of social distancing that people are doing, and I'll talk a little bit more about social distancing in a minute, sort of what the timing of the peak number of cases we expect to see in our hospitals and how many beds we might need. And so you can see there on the topic across the entire United States, they're currently estimating the peak to be around the middle of April. And at that time, we will need over 200,000 total hospital beds to care for COVID patients and about 33,000 ICU beds. And you can see how many we have. So we definitely have a surge that we need to do to increase that capability if we're going to be able to care for these patients. And we're already seeing in parts of the country, particularly New York City, where that demand is being exceeded. But I think this modeling is extremely helpful. It does change depending upon how much social distancing you can get. So there has been a huge effort in the United States It has varied some from state to state, but because our state was one of the first to have cases, we took this very seriously. And the governor shut down pretty much every social gathering over 10 people. He shut down all of our restaurants, our bars, our all conventions, conferences, all travel. And now we are in a stay-at-home or shelter-in-place order. So if you're not working in a critical function, like working in a hospital or other critical job, you are actually not supposed to leave your house. There's signs on the freeway telling you not to be out. And when they do have meetings, and this was a meeting where they were setting up a field hospital in our football stadium, you can see that people have to stand at least 6 feet apart. So this is the idea that we can reduce the spread of the disease, sort of flatten the curve, as you will, so that while we still may have the same number of infections, if we can spread them out over a longer period of time, that will allow the healthcare system to keep up. So this has been a huge effort. It's a tremendous hit to the economy. It's led to large numbers of people being unemployed. And so there are bad consequences to this, but at the same time, we think this is the only way that we're going to be able to meet the demand from a healthcare system perspective. And so we are adhering to this very strictly, at least in our state. If you look at the comparison of the modeling based on different states, you can see here, again, some advantage to having the first case is that our curve in Washington is flatter than the other states. And we think that's because we were up on these social distancing issues early. We started out at the same pace, but we've been able to flatten our curve. We hope that it'll continue to flatten. Unfortunately, places like New York, here, and Michigan, which has Detroit, those places continue to escalate. And so we are challenged, particularly in cities where people live very close together, and it's very hard to do social distancing to be able to get the same effect that we've been able to get in Washington. And so to the extent that you can achieve this in your society, the social distancing concept, I think, is critically important. As you can see, this is again modeling from that same group at the IHME, that different states are likely going to peak at different times. New York, again, because they're accelerating so rapidly, will probably peak earlier, but we're hoping to actually drag this out longer by social distancing across the country. But this kind of modeling, again, from epidemiologists who are really heroes in this event, is really helpful in our planning. And so I don't know what it looks like for you, but I think I'm sure there are people that are smart enough to help figure it out, because I think this type of planning has been very helpful for us to know how we need to preserve and gear up our staff over time. So I'm going to stop there. I will say that I'm incredibly proud of our team. This is a social media post from our emergency department team encouraging social distancing. I put here 2 links to our websites. These have all of the hospital policies, procedures, protocols for everything that relates to COVID. They're open access. You're free to download anything that you need from there. They've tried to share as much as we can what we've learned so far, and we're still learning, I think, every day. Every day we find something new where we have to make a new policy or procedure. I'm going to stop there. I probably went over my 10 minutes a little bit, but I had a lot of information I wanted to share with you, and I think we have plenty of time to try to answer your questions, and I'll turn it back over to Dr. Al-Turki. Thank you.
Thank you very much, Eileen, for a wonderful presentation and for the highlights you have presented of the activity done at your states and also the American College of Surgeons work and recommendations. There's a lot of things to discuss, and I just want to start with, you know, in Italy, there's 10,000 infection among healthcare providers. And you have already touched the work done for the staff and the precautions and support for the health staff. I have 2 questions at this part. First, how what is the most important steps to protect the staff, number one. And number two questions is, if we look at the mortality, it's still around 1.3 in the United States compared to 5 and sometimes even 6% in some of European countries. Why, in your opinion, is that? So those are two questions, if you don't mind.
Sure. So we are absolutely concerned about the risk of exposure to healthcare workers. We don't know why healthcare workers seem to be at greater risk. There's some concern that the increased rate of exposure puts people at greater risk. In any case, the key is to protect the healthcare workers, and we think that the key to that is appropriate use of personal protective equipment. That's masks, gloves, gowns, all those face shields, all those things that limit exposure to the virus. If you're working with somebody that is known to have the virus or at high risk for having it, then we recommend airborne precautions, which means the use of a N95 mask or a PAPR device. If you're working with sort of routine patients that are not likely to aerosolize the virus, they're not intubated, they're not in the ICU, then you can use droplet precautions for managing those patients, because that's the most likely means of spread, which is a more regular mask. But in any case, I think the key is having enough personal protective equipment to provide to our healthcare providers so that they're protected in every interaction. And to do that, we have to have protocols around how it's used and how it's reused, because we're not going to have it forever if we burn through it all quickly. So we have worked very hard to define the appropriate circumstances for different types of PPE, and then we have reuse protocols for PPE as appropriate. But you'll see on the news, there's a lot of anxiety around whether or not we're going to have enough to get through this crisis. Your second question was about the overall mortality. And I think that's spread across the entire United States, right, where we have parts of the country where we have huge outbreaks, and then we have parts of the country that have not seen a lot of cases yet. I worry that the mortality rate in places like New York is going to be much higher, just because of the huge number of patients that are impacting the healthcare system there. I think we'll just have to see how it is over time. But our goal has been to try to distribute patients among the hospitals so that we can still provide the standard of care that they need. Have we lost the sound?
But at the same time, you said there's a difference when you have a hurricane, which is one event, and you just handle the aftermath of that event. Or even if you have an earthquake, you might have one followed by 1 or 2 earthquakes to follow. But this is a different situation that lasting for some time. So in your opinion, what are the main differences between natural crisis, earthquake or hurricane, and this type of crisis?
Well, I think there are a number of differences, and I think it's important that we remember those when we are planning, because I think the differences are that it affects every part of the healthcare system. It's not just confined to a small region or a small area. It's every healthcare system, part of every healthcare system in the world, quite honestly. And so it's straining that entire system. And I think the other key difference is the risk of exposure to workers. You know, if you're taking care of people after an earthquake or after a bus crash or whatever, you yourself are not directly at risk usually. I mean, you can be, I guess, if the building's unstable, but you feel generally safe when you're taking care of the person. And that's not the case here. So I think that protecting and caring for our healthcare workers throughout this whole process is going to be critically important. And because it is such a long, drawn-out process, I think it's easy for people to get exhausted, to get overstressed. And so we have to figure out how to maintain the ability of people to respond over a long period of time.
You mentioned a very important point that's part of the planning is to look at the spacing, especially the negative pressure space to have a surge capacity. What are the examples of those places you have chosen?
So, and I'm not an engineer, but our engineers have been really fantastic because they have basically gone through each part of the hospital and looked at the ventilation system and figured out how to turn what is normally, either regular space or positive pressure space into negative pressure space. So I don't know exactly how they've done it, but we've taken higher floors of ICUs and turned them into negative pressure. And we have mapped out every hospital bed in the hospital where we can turn negative pressure and a sequence to do that as we need to expand into other parts of the hospital. So I would engage your engineers in your hospitals to start to look at that.
We know that those people who need to be admitted to the hospital are the people who really need high flow oxygen and possible ventilation. Have you reached, or if you reached a stage where you are overwhelmed, have you put your triage criterias home to ventilate or not? And
so we have not had to do that yet.
Sorry?
We have not had to do that yet, but I know certainly Italy has faced that. And I have been on webinars where I've heard, from the folks in Italy that they've had to set age limits on who they can put on a ventilator and things like that. We have not faced that yet, but that's why I think it's critically important that as a healthcare system, we have those discussions and we're very transparent with the public about how those decisions are going to be made. Because if we get to that point and we have to make those difficult decisions, then I think we want to be as transparent as possible about it.
You have mentioned in your presentation that you are thinking that the peak of this outbreak in the States, at least, and I have also read a lot of people talk about mid-April. Do you think this is realistic? And they talk about possible second wave. And also, we just heard in China, Wuhan now has locked down also back to curfew after they indicate they have cleared the cases. The reason I'm asking about that is that we are very happy about, as I mentioned earlier, about our government taking this serious, and we start to see decline in cases. When do you think that people should go to normal, or what's the time frame we're talking about?
I really wish I could answer that. I think we don't know. The modeling is an estimate, right? And I think the whole goal of social distancing is to stretch out that model. To actually, if we do social distancing well, less people will get sick. They'll get sick over a longer period of time, and we'll be able to manage it. But that extends the time, right? So I have no way of predicting that. And I think there's a lot of fear, as we've seen with other influenza type events, that there could be then another outbreak again in the fall. So I just think we don't know. People are trying to make their best guess. Our state has extended our stay-at-home shelter-in-place order till the end of April, but they may extend it again. So I think we just have to sort of see how it evolves. What we need really is a vaccine, and there are lots of people working aggressively on that. And I worry that we're going to kind of have these intermittent peaks and outbreaks and things until we get to the point where either so many people have been exposed, right, that it's more like influenza, or we have a vaccine to help manage it. Because this is just something that we've never seen before in our lifetimes. Hopefully we never see it again. But there's just not enough immunity to it in society right now.
Eileen, I have a last question from my side, and then while you are answering this, I will go and check we have almost now 1,000 questions from our participants. We are grateful for their participation and their engagement. My question is why places like New York is continue to go up. I know it's mostly densely population. Is social distances is enough? Do you think that, curfew, which has been done by a lot of countries, they have total lockdown of the whole population, only, going out for essential, food, etc., but not allowed to go even out. So if you touch the base, why you think the curve in places like New York just continue to go up, and when they can break it? While you're answering this, I'll just go to see if the team could summarize some of those questions, because I don't think we'll be able. Now we have 1,031, and the number is going up, and just showing the engagement. And the people like what you are talking about. So if you don't mind to answer this, and I will just see and go through the questions if you don't mind.
Yeah, I mean, I think it's tough, right? I think any place where people are densely living together, it's very hard to do social distancing. And this is not unique to New York. I think we're going to see this in other parts of the world. We have many cities in the world where people live very closely together, and also where people are living in poverty. And unfortunately, it's going to be even harder for them to effectively social distance. And so I fear that in our large cities around the world, we're going to see these kinds of outbreaks that are very hard for the healthcare system to keep up with and for the healthcare system to manage. I think that's the main issue in the larger cities. It's just not feasible to decrease the rate of transmission as much as we would like.
I have, I've been through you can hear me?
Yep.
Yeah. A lot of questions about the use of laparoscopic surgery coming from our audience, and a lot of questions about trauma handling during this outbreak. I know you have touched the base of of evacuation of CO2 and using of filters and the aerosol generating procedures that you are cautious with. Do you mind touching base with the laparoscopic procedures, and as well as trauma in particular? What are the challenges? How you handle your trauma? Do you triage also your trauma? And when, where is the line between, if you are overwhelmed with COVID-19 cases, the risk of closure of the hospital and not handling a trauma? There's a lot of questions around that. So, yeah, if you don't mind.
So, I'll start with the trauma piece. So, from a regional planning perspective, we have a trauma system, and so we have some hospitals that specialize in trauma and receive most of the trauma, and other hospitals that don't. And so, as we're dealing with the regional distribution of patients for this epidemic, we're actually trying to protect the trauma centers some, so that there's still capability to receive those patients and offload injured patients from the other hospitals as well. So I think that trauma, if you have stroke centers, if you have cardiac centers, hospitals that do unique things in your system, that you should work as a system to try to preserve some of that capability, so that if somebody is hit by a car, they can still get treated, and not die from that when they otherwise wouldn't. So from a system perspective, we're looking at the distribution of patients among all the hospitals to try to protect a little bit the trauma and burn centers from that. The other pieces to trauma, so when you're responding to the emergency department for a trauma activation, you're going to see a patient, you don't know what their COVID status is. And so if they are awake and talking, we can ask them if they had any respiratory symptoms. If they have, we put a mask on the patient, and we test them. If they haven't, then we'll assume that they're negative if they can give us a good history. But if we are dealing with a patient that's already intubated, or we can't get a history, they're unconscious, we don't know, then right now we're treating them as if they're COVID positive, which means that we have to respond in full airborne precaution PPE, and we test them. And fortunately, this week we got a rapid test. So previously our test turnaround time, it started at about 3 days. We got it down to about 12 hours. And then 2 days ago, we got a rapid test that takes about 45 minutes to run. But because the samples have to be batched, it takes about 2 hours to get a result. So for trauma patients, we're now testing them with the rapid test if they're unknown. And if they come back negative, then we can clear, not use as much PPE to take care of them. But all these are factors that, you don't usually think about when you're taking care of trauma patients that all of a sudden you have to start to think about because you don't want to expose your healthcare workers to somebody who might be positive and you don't know it.
Thank you.
You want me to talk about laparoscopic surgery now?
Yeah, please.
Yeah. So yeah, there's been a lot of debate about laparoscopic surgery and emergency general surgery, in general. So, things like routine things that come in all the time, appendicitis, somebody needs their gallbladder out, acute cholecystitis. So there's been some debate. Should you not do those operations? Should you do them open, not laparoscopically? And there's been a lot of discussion around this in the surgical community. I think what we've settled on is you should do the right thing for the patient. And if they need an emergency operation and you have the resources to do it, you should do it with appropriate precautions. And so, as I said, using smoke evacuators and COT filters, but not converting all operations to open, not avoiding all operations. If you get your appendix out and go home, that's probably better than sitting in the hospital for 3 days on antibiotics or something like that. So it's reasonable to do emergency operations, just take appropriate precautions to do them.
Thank you so much. I have a group of questions about the testing, and you have talked about this. Some questions, they say, if you don't have that many numbers and you want to test everybody, is that necessary? The second question is, you have mentioned that most of the cases stay 2 weeks. Is that in general? Is that people with comorbidity? Is that an average of everybody? And what's the longest time they stay in ICU? So I have a few questions on that, if you don't mind.
Yeah, okay, so I'll take the time piece first. So that 2 weeks is what I was referring to is from people around the world. They're basically saying if you get put on a ventilator, you're generally on a ventilator at least 2 weeks before you start to get better, if you're going to get better. So that makes it tough because if you're trying to decide, is this person getting better or not, or that, should we withdraw care? You have to wait a long time to sort that out. Some patients, obviously, who have lots of other medical comorbidities, who are very sick, they may die sooner than that. But in general, what the critical care specialists are saying is that it takes, especially if you have a young person on a ventilator, it takes you a couple weeks to see how they're going to do. And so their ICU stay is actually probably longer than that. What that means is that over time, even though the number of ICU cases is smaller than the number of people infected, they're adding up because they're staying in the ICU so long that you keep adding more patients onto that. So I think that's just something we have to be thoughtful about when we're preparing for our surge capability, and know that even if our peak is somewhere in the middle or the end of April, that we're going to have patients in the ICU a lot longer than that. Patients that don't need to be in the ICU, many patients can go home with this disease and be quarantined at home if they're otherwise healthy. The people that are in the hospital tend to be people that need oxygen, that maybe are not sick enough to be on a ventilator. And their length of stay in the hospital varies depending upon their comorbidities. So it's really hard for me to give you an estimate, but we have seen that people tend to be in the hospital for, on average, all comers 2 weeks, but really ICU patients much longer than that. I forget what your other question was. Oh, testing everybody? Well, we've not had the luxury to try to test everybody. you know, I don't know what that strategy would look like. I think the challenges are a lot of asymptomatic patients. And I wonder what would happen if we tested all of our healthcare workers and half of them were positive but not symptomatic. Would we send them all home? I don't know, right? So, I don't know anybody that's tested everybody, but you'd have to make decisions around who could work and who couldn't work in that situation, I think.
Thank you. I have a question, actually more than one, regarding, you said there was 129 cases in a single facility being infected. And a lot of questions also related to that. Is the infected or the chance of infection is happening because it's not when you are geared and you are dealing with a well-known case of COVID, it's in another open places where you treat people and considering them negative. I know now you are taking precautions, but is that a reason for this vast spread? And there was also other questions related to the strong spreading of this disease. Is that something, there's questions around this, have you seen something like that? Is that a peculiar virus? Is that something that's highly contagious? So there's a lot of questions around this issue as well.
Yeah, so what I understand from the scientists is that there's a very high rate of viral shedding with this particular virus, especially in the early days of the infection. So there's a concern that there are some patients who are asymptomatic who may spread the virus without knowing it. And then those that are sick in the first 5 days or so, the rate of viral shedding reportedly is much, much higher than it is with other similar viruses like influenza and so forth. So the risk of transmission from person to person is much higher. That initial outbreak we identified, you know, in a single facility had far-reaching effects because the people who worked in that facility worked in other facilities, you know, and basically it spreads so easily that, you know, you're doing contact tracing, which is what you do in most epidemics early on, where you're trying to trace each person the person came in contact with, then you can identify lots of infections that way. Over time, we've had to stop doing contact tracing because it's just so widespread in the community, and just have to sort of assume that somebody might be infectious and try to tell them to stay apart from each other. But I think it's a high rate of viral shedding that is maybe a little bit more aggressive for this virus.
We promised Dr. Wissam, who is the Executive Director of Academic Affairs in the Saudi Commission, to finish on time. We have 2 minutes to go. I really cannot thank you enough, Eileen, for your precious time, for sharing with us your experience, and also are grateful to the American College of Surgeons for also sharing with us their knowledge and expertise. I apologize for, first I would like to thank our audience who's been listening to us for 1 hour. And I'm sorry I could not address all the questions. There's 1,300 questions, but I tried to cover the main areas. So again, I apologize for them not covering all their questions, but we will try to address them later, and we might be able to answer them in writing. Dr. Wissam will join us, but before Dr. Wissam join us at the end, I would like to remind our audience that the Saudi Commission for Health Specialty continue their activity, and the next session will be the approach to patients with severe COVID-19 from one of the experts of ICU, Dr. Yassin Arabi, who is a leader in this field, and he is the chairman of the ICU department at the National Guard Hospital, King Abdulaziz Medical City in Riyadh, and it will be on the 5th of April at the same time, 7 p.m. So thank you, Eileen. Thank you for the college. Thank you for your time, and thanks for our audience to be with us. And we finished on time, so I know everybody's time is precious. I know there is a lot of things to cover, but I think we covered most of the issues here. Thank you very much.
Thank you very much, and I wish you all very well. Please stay safe.
Thank you, Eileen, for your time and for your efforts, and thanks to the American College of Surgeons for this amazing collaboration. And we look forward to future ones, inshallah, in the near future. Thank you again for your time. Much appreciated.
Thank you.
Thanks.